Dr. Nikunj, orthopedic surgeon, joint replacement surgeon from Max Hospital, Vaishali, who will be taking the next talk. He'll be talking about healthy bones, aging of the bones in knees and joints. I would like to call upon Dr. R.K. Mishra, sir, Professor of Orthopaedics at VIMS Gajraula, to please chair the session, and Dr. Harmeet, sir, to please co-chair the session. Please have a round of applause. Dr. Harmeet, sir, please co-chair. We must thank Dr. Nikunj. He's 5 minutes and he's ready with the talk for all of us.
I'm Dr. Nikunj Agrawal. I'm a principal consultant and unit head. So I'm practicing at Max Healthcare, Vaishali and Max Noida for I've been in practice for last 17 years, and I'm mainly into joint replacement surgery and arthroscopic surgeries. So topic I've been asked to deliver today is on aging knees, and just in a matter of few minutes I've gathered what I could. And today we'll be talking mainly about how to celebrate second innings of life with the recent advances which we have got in the terms of treatment of these aging knees. Now, when I talk about second innings, now why this second innings come into play is because there are many terms which are commonly used, like elderly or old age. Let me just give a broad and new definition which is given by WHO, and which says that till 65 years, the WHO considers it as a young age. 65 to 80 years is considered as a middle age, and only after 80 years, the WHO considers it only at that point of time as an elderly age. So it is very important to understand that our mindset needs to change. And though I keep giving many talks at various conferences, but I always talk about this mindset because when I was doing my PG and registrarship, I was also having the similar mindset that shayad 50 years, 55 years or 60 years ke baad people usually retire. They have nothing much left to do, and they've just got to do the basic things. And more than what they think, their family, their relatives, they start saying कि शायद आपसे नहीं होगा, आप रुक जाओ, हम कर देते हैं. So it is more of a mindset which comes into play. So even the small things like getting milk from the market or getting fruits from the market, they stop doing because this is what have been imposed, that probably it is a retirement time, and since the work is gone, so probably you are not fit enough to do anything else also. So, but when I went abroad, probably, I'm not just comparing the things, just I'm talking about a mindset. When I came back from my fellowship, I was doing my fellowships, the cab which I used to go to the hospital, the driver was 83 years old. And I asked that driver that, sir, you are 83 years old, what is the need for you to drive and daily come at 6 o'clock, pick me and take me to the hospital? He was a little bit upset, and he was just like, why not? I'm 83, so what? I have to be fit. I have to do everything what I used to do at 50. I have to run marathons. I have to do swimming. I go swimming and at my clubs and all that. So this is just a mindset which clicked me at that point of time. And when I returned back, I really thought that probably there is something which is restricting us from doing what we can do actually. And our science, our medical science have been excellently doing very well in terms of, I would say, mental health and all other departments. But this mechanical health, probably the joints health, is usually taken for granted. Because ये तो शायद aging है, ये तो शायद age related issue है, ये तो सबको होना ही है, probably it doesn't have a treatment. And so it is important just to understand that again, this mammoth disease or a pandemic which is there is also a disease, and we should consider this not as a part of aging, but also as a disease which has treatments. And once we get through those treatments, we can get back to the racing track as swiftly and as energetically as we were in 40s or 50s. So again, it is a future shock, and we all know that as with the aging, with sports injuries, with increasing obesity, our knee joints are going to get affected very, very badly and very, very fast as compared to any other joints. And so we need to take care, and we need to know first of all what we need to do in terms of taking care of our knee health. Considering females are much more prone to get knee arthritis because of the hormonal factors, because of obesity, and all many other issues. So we need to know that after menopause, especially certain things have to be taken care in terms of bone and joints health, especially in terms of females. I won't be going too much into details. It's a very long talk, so I've just concised it for So this is a routine case which comes to us. A 65-year-old female with pain and swelling in the joints. early morning stiffness after walking, and history of knee injury. Now, this is an orthopedic OPD patient. If we don't talk about an orthopedic OPD patient, if we just talk about a general medicine OPD patient, even that patient who comes to you with a medicine, with a diabetes or with a hypertension treatment, he or she still has knee joint problems, though which he or she does not feel important to discuss, because he or she feels that probably it's just a part of aging. So it is important to understand that again, what stage that knee joint is getting affected, what kind of arthritis it is, and definitely there is a cure and treatment for that arthritis. Just a small video on to know what exactly is arthritis. We all are aware it is just a cartilage problem. In between the femur and knee joints, we have articular cartilage and meniscus. And as the knee advances, as we go towards the second innings, there is wear and tear as we have it in our car and automobile. Similarly, our joints, while taking the load of our body, gets into into this wear and tear of this articular cartilage, which exposes the subchondral bone, and again that is the cause of main pain, and ultimately there is deformity, there is severe pain, and other things which are associated with it, which patient usually ignores. Next, I would say. Okay, so this is the worn out cartilage, and cartilage is hardly 8 mm thin. So it is just a small cartilage which is causing the wear of cartilage, which is causing the problem, and it is just a wear and tear of the cartilage, which is the main prime reason for all this. Diagnosis mainly by examination, imaging, and lab tests. These are the basic clinical diagnostic factors. We have a joint line tenderness, crepitus, stiffness. In late stages, we get deformities. And this is the simple X-ray which we all can get done for our patients. And we very clearly know that there is equal joint space in between both the knees, joint compartments in the normal knee, and as the knee starts to degrade or degenerate into a severe arthritis, the space between the joints gets degraded, gets diminished, and there is bone-on-bone arthritis in the later stage. MRI is usually done in the early stages or in the younger age, especially in 40s and 50s, where we can diagnose ligament tears, meniscal tears, which can be dealt very easily with a small arthroscopic procedure, which we usually do. Now, important to understand is the management aspect, and the most important aspect is the education and self-management. Usually, people relate knee treatment with joint replacement treatment. So, I would like to just throw some light here that in my practice, I usually advocate joint replacement in less than 20% of my knee joint problem patients. So, the knee replacement is not the only solution for any knee joint problem. There are many, many solutions, and in fact 80% of the problem can be dealt with either smaller or milder methods like exercises or some injections or some other procedures other than joint replacement. Important is to understand and to educate our patients regarding self-management. It is important to know what is right and what is wrong. It is important to tell them what exercise to follow. Weight loss is an important factor, and use of suitable footwear again is important. Just a show of hands, how many of us regularly do swimming here? Good to know that. And cycling on regular basis? Yeah, absolutely, absolutely. So, and walking, of course, every one of us must be doing. Important to understand that swimming is the most important exercise for our knee joints, followed by cycling, and walking should definitely be done so that our tonicity of the muscles are maintained and the knee joint does not get that much load. Regarding weight, important principle, we all know physics. Our body gives 4 to 5 times the body weight on one knee joint while walking, and about 8 to 10 times the body weight while running. So if we are weighing around 60 kgs, our particular knee weighs about 300 kgs. So it is a mammoth weight which falls on a knee joint, and that is the reason knee joint gets degenerated very fast as compared to all other joints. So it is just a matter of just a small knowledgeable fact that if we reduce 5 kgs or 10 kgs from our weight, then 40 kgs of force reduces from our knee joints, which ultimately limits further injury, increases mobility, and decreases the chance of worsening of arthritis. Stretching exercises, very important for our muscles and joints, should be regularly done for all our joints, and at least 5 to 10 minutes daily in the morning we should advocate towards stretching exercises. Coming to physiotherapy, early stages of arthritis definitely feels much better with physiotherapy and some modalities, but should be done only in early stages. These are some basic knee strengthening exercises which one can do at any time during after getting up from bed. Just need to devote 5 to 10 minutes, and we can all do all such basic exercises like heel raises, butt kicks, knee extension can be done just to maintain good knee health and good tonicity of our muscles to prevent and delay the worsening of arthritis. Again, similar concept, if we just take one stick in our hand, if we have a knee problem, if we take a stick in our hand which shares our load by 20 or 30 kgs, similarly the weight falling on our knee joint gets drastically reduced, like the way we are talking about weight reduction. Similarly, walking sticks and aids gives a much better relief for our knee joints. Yoga, other alternative therapies, occupational therapies, very, very crucial and very, very good for our all bones and joints, but should be done only for those who have been doing regularly yoga practices. Those who have not done yoga at all and those who wish to start yoga at 65 or 70 probably should take it as a word of caution, because that time the elasticity of the tendons decreases and the chances of injury increases. Medications, painkillers are usually prescribed for most of the such patients, which I'm usually not fond of because they have battery of side effects. Glucosamine and chondroitin sulfate are one of the good agents which provide very good relief without having much side effects. We all know the side effects of painkillers, so it's usually not the right way of going it forward. Injections, intra-articular injections in the form of corticosteroids, viscosupplementation, or stem cell therapy or PRP, I routinely use in my practice, and they have got fairly good results. But we need to pick the patients rightly, because if we put it, if we give injections in a very severely damaged knee, probably it will not last for long, and it will be only acting as a pain relief for few weeks. But if we give it in the right stage, in the early or moderate stages, a viscosupplementation can give a relief, can provide relief for good about 8 to 9 months or probably an year as well. PRP I routinely use in my practice. Again, usually given in the form of 3 or 4 cycles. In early arthritis, it provides good relief, but the first cycle is usually painful. So the patient compliance is not very good. So patient usually never comes back for the second cycle. But if the patient holds back and tries to complete the procedure and with the 3 cycles, it usually gives excellent results. There are some studies again which says that all these injections are good for early treatment, good for early osteoarthritis, systematic reviews and everything. Stem cells are still under trials, not very good long-term results, but yes, this has been started, and we have started giving it for last 6 months. Again, limited high-quality evidence and long-term studies regarding stem cell therapies. Therapeutic arthroscopic surgeries, I told you we usually do it in early stages, and in younger patients if we have meniscal tears or ligament damage. It's a daycare procedure, painless, laser assisted and accurate, with promising results, and patients are able to walk immediately after surgery. So if there is a degenerated meniscal tear or there is a degenerated ligament tear, it usually works very well after such arthroscopic procedure. It is less expensive and usually a daycare procedure. Other options, of course, high tibial osteotomy. If a patient is a good build, 40, 45, 50, early 50s, not bone-on-bone arthritis, early arthritis, usually I advocate high tibial osteotomy. If the patient is having severe deformity, the alignment is changed so that the weight-bearing axis is changed and the pain gets relieved. Partial knee replacement, again, it's an important concept. Not many of us in the general population know about it. Now, if we are replacing if we are resurfacing the entire knee, and if only one of the sides is getting damaged, the rest all sides are healthy, then it is quite, it's logical. Why not to treat only that one compartment? Now, with this concept, this single compartment osteoarthritis, there's a partial knee replacement which is very well done, and we have got very good implants available from many companies, and they provide very good relief. Usually, so this is what a partial knee replacement post-operative X-ray looks like. So rest all the compartments are not resurfaced, only one of the compartments is resurfaced, and usually patient is up and about in 2 to 3 days. Patients are able to climb stairs by the end of 5 days and are able to do all activities because the ligament and all other soft tissues are usually maintained intact. But in severe knees like this, with severe deformity, severely painful, bad deformity and gross malalignment, we usually go with what is called as, so this is an arthritic knee, and as you can compare with the normal knee, you can see how bad the alignment can get if the patient is neglected or the patient neglects himself. And ultimately, we usually commonly get this in our OPDs, referred from other doctors or from peripheries, and we have to ultimately undergo something called as knee replacement. Again, a misnomer, because it is not a replacement anymore, it is just a resurfacing procedure. And so there are many myths associated with this total knee replacement. It is not a total knee replacement, it is just a resurfacing procedure. Another myth is a patient cannot sit cross-legged. Again, a big myth, misconception. Patients are easily able to sit cross-legged. In fact, now the concept which have been gaining momentum is what is called as high performance knee replacement. Now, when I came back from my fellowships, probably 12 years back, the only expectation a patient had if he was coming for a knee replacement was कि डॉक्टर साहब मैं बस चल फिर लूँ, अपना काम कर लूँ, बाथरूम टॉयलेट चले जाऊँ, that's all. मुझे और कुछ नहीं करना है. Now, with the time, there has been a dramatic shift. Now I get patients saying, सर मुझे स्विमिंग भी करनी है, मुझे मैराथन करना है, मेरे बच्चे की शादी, मुझे उसमें डांस भी करना है, मुझे पहाड़ों पे भी जाना है, मेरे को ये सब काम करने हैं. So, क्या ऐसा हो सकता है? And definitely the answer is yes, because with time we have got advances in all aspects of knee replacement, be it prehabilitation, rehabilitation, be it what we call the implants and the techniques, the pain control methods. So we have got all these very well advanced way. So this is what is a resurfaced knee looks like. It's just a cap, metallic cap, which gets fitted on the end of the knees, and the alignment gets restored quite well after such a procedure. So patients are sitting cross-legged comfortably. I don't have much videos with me because it was just a short information talk, but we are able to do almost everything. I've got videos of 93-year-old gentleman who was dancing at his grandson wedding after a knee replacement surgery, feeling as fit as ever and feeling like 50-55 from heart. So it is actually a life-changing procedure nowadays with 99.9% success rates, I would say, because with good backup, good systems in place, good protocols in place, and with dedicated teams, the chances of errors have got minimized. Yes, there are risks of infection, but if it is done in a setup which is very well made for that, the OTs are made for that, and the pre and post-op care is taken, the chances of infection are hardly less than 0.1%. So it's been done for last 20 years, most successful surgery, very safe, long-standing results. And it lasts for at least 25 years. We have got latest implants made up of gold or coated with gold and oxenium, which claims to have longevity of about 30-35 years as well. Again, the new techniques are in place. We have got robotic joint replacements now. We have been doing robotic joint replacements. Very good early results, but long-term results are yet to be proven. But yes, patients are able to get on their activities very fast as compared to conservative methods. Thank you so much. Treasure your bones, and I would say your body is the only place to live, so just keep it healthy. Thank you. Thank you, sir. Thank you,
sir. Thank you, Dr. Nikunj.
Thank you, sir.
This was a good presentation on knee joint.
Thank you.
It was just like a lecture.
Sir.
Taught everything, fast and furious. You said the second inning.
Yes.
So I think in knee joint there should not be any second inning.
Yes, definitely.
So, but anyway, your presentation was very good.
Thank you. Thank you. Yes, sir.
One thing, I want to thank you for one thing. You told ki all your knee surgeries, you are going for only 20%. I am taking it 30 to 40% also. Then also it is thanks to you, because you know ki what is going on. It is more than 60 to 70% knees they are doing, or it is not needed to, because knee, it is not in the knee, problem is somewhere else also. And one more thing, it is for you. And whatever I thought in knee aging and all, not in the anatomical thing only, it is physiological. Yes, sir? That much I understood, sir. Thank you, sir.
Actually, in the management, overall orthopedic surgery, orthopedics, we have all forgotten only one thing is there, knee joint. So 80% of surgeries are being done on knee joint, and the reason you know. Thank you.
Dr. Nikunj, one small question. I used to be a runner. Many years ago, I've gained much weight because I was advised that probably your running is not good for you, or probably I read it on Google. So you mentioned that walking is 8 times more force and running is 16 times, and swimming is the best. So would you say for like people my age or in their 20s, they should, I mean, just focus on swimming and not take the other sports? Or what would you
suggest? The
suggest?
first important thing which you need to take care is the weight. Now, if you reduce the weight, now automatically the pressure on the knees gets reduced. The activity comes obviously if a obese person starts to run, obviously the knee is getting much more pressure or force as compared to average built individual. So regarding activities, yes, swimming has got a dual force. Swimming has got a dual force. It has got a buoyant force also. So the entire weight is not coming onto the joint, but the muscles and the tendons are getting flexibility. Is much better as compared to other means of walking or running, or because we don't have a solid or a firm ground on which we are getting the force. So swimming is definitely much better. So if the patient is obese or I would say if the patient thinks that I wish to start one thing for I can do only one thing, then probably yes, swimming is the best exercise. But if he cannot or is not able to do swimming, he doesn't know swimming, then obviously cycling or walking, other modalities should definitely be into the routine.
Thank you, and I must congratulate you. Great talk, and to come up with it so quickly is, I don't even no words. I will ask the chairpersons to please give a token of appreciation. Sir, for you also.
Actually, he is my student.